New people, some of you don't know this, but this is our 6th year of doing this, and the talks get better and better and better. Now, show of hands, how many of you know what a physiatrist is? Raise your hands. Oh, that's about a third, I guess. Okay, so let me explain. A physiatrist is a physician who is trained in physical medicine. What does that mean? Well, they don't cut. They are trained and they help people recover from whatever is ailing them, be that a torn muscle, an achy pain in your knee, serious injuries in an automobile accident, and anything else that requires getting you back to where you were. The object of all medicine, whether you're a surgeon, an internist, an obstetrician, or whatever, is to get you, the patient, back to where you were when you started. That's the first thing I learned in medical school. It's something I teach all my students now, and I carry it with me. Remember, when you go to your doctor, his job or her job is to get you back to where you were and want to be. Sometimes you can't do it, but much of the time you can. Dr. Galmer works for New York Presbyterian Queens. She is a physiatrist. She is trained not only in taking care of knees, but she's trained in something called regenerative medicine, which she is going to talk about a little bit today, which is a new subspecialty, which is something very interesting and is now available, and so on, stem cell stuff. And she primarily works with orthopedic patients, but can deal with any kind of injury. People with strokes, people with orthopedic injuries, people with knee problems, and she also has special training in osteoporosis, which is coming back again as a hot item in medicine. It was at a peak of interest 15 years ago. It ebbed away, but we're learning more and more about it and getting real facts about treating that. She's a, pardon me? Okay.
You can postpone the restart, because this is press
okay.
postpone.
In addition to all of this, she has 3 kids, and she is a very active and amazing woman. And I want to introduce her. Please, you want questions later or any time?
I think I'll save questions for the end.
Okay, save your questions for the end. If you want to, I'll give you a pen and a paper to write them down, and I'll give them to people later. Thank you.
Thank you for having me. Can you guys all hear me? So today I'm going to be talking about knee pain. It's a big topic, obviously, and as Dr. Bright mentioned, my area of expertise is in non-surgical treatment of knee pain. Basically, this lecture is going to be an overview of knee pain, what is the knee, the anatomy, what can cause it, and some of the treatments. We'll go through that. I'm keeping it short-ish so that we have plenty of time for questions, which I'll ask if you don't mind to save to the end. So, all right. So knee pain is obviously very common, very prevalent. A lot of people suffer from it. About 100 million Americans suffer from chronic pain. A big percentage of that is knee pain. It's the second most common cause of chronic pain. The first is back pain. 1/3 of Americans report experiencing knee pain at any one time on average, or if you look at other statistics, about 15 to 20% of men and about 20% of women. So it's a little bit more common in women. Osteoarthritis in general is the most common joint disorder in the world. It's also a leading cause of pain, loss of function, and disability in adults. And this statistic is 10 years old, but in 2008 there were 600,000 total knee replacements performed in the United States, and obviously that number has gone up significantly, not to mention the number of revisions that also have to be done, so a lot of knee surgeries being done. So if you want to understand what causes knee pain and how to treat it, you have to have a basic understanding of anatomy. So the knee is made up of 4 bones, the femur, which is the thigh bone. Let me see if I can get this thing here. Okay, well, the femur or the thigh bone, the tibia or the shin bone on the bottom, the fibula is a little bone along the side, and the patella is the kneecap. Just for reference, there's an x-ray on the bottom corner there of the exact same picture, so when you get a knee x-ray and your doctor shows it to you, that's what you're looking at. You see the, I'm blocking
The
it?
X-ray.
I'm blocking it.
The clicker's not working, like you
You're
said.
standing right in front of it.
Maybe I'll stand on this side.
Is the clicker not working?
The clicker's working.
Oh.
The point.
No, it's a double, I think it's either a double or triple like that battery.
That looks good, actually.
Can you guys see the X-ray?
right?
Yeah, that's.
That looks good, the X-ray, right? That's.
That's a
Can you
good
just-
X-ray.
Can you use the laser for a second?
Use the laser. Uh-oh, sorry, the wrong button.
Are you going on?
Spacing.
No, it is working.
Is it working?
Well, I don't think the laser out, let's see.
Yeah, the laser doesn't work. It's okay, we don't need it. I never use laser pointers.
Okay.
I was gonna try it.
Everything's breaking today. Today's breakdown day.
That's okay. So anyway, for reference, like I was saying, there was an X-ray on the bottom. I'll just use my hand. So you can see the joint space in the middle, that's between the two bones. This is the femur, this is the tibia, the fibula, you can see the head of it right here. And then you can kind of see this circular shadow in the front, that's the kneecap sitting in the front. Just so you know what you're looking at when you go to the doctor and get a knee X-ray. Next is the ligaments. The ligaments are what hold bones together, so they're these kind of ropey things. They're not meant to be elastic or stretch. They hold the bones together, mainly the tibia and the femur and also the fibula. So you've got the lateral collateral ligament, which sits on the outside of the knee, the medial collateral ligament, which is on the inside of the knee, and then you've got kind of a crisscross from front to back to front, and that's your ACL and your PCL, or your anterior cruciate ligament and your posterior cruciate ligament. And also you've got the meniscus, which is these sort of C-shaped discs in the middle between the joint. Those are, they act as a cushion and they kind of allow the top bone to slide over the bottom bone more easily. A lot of times we hear about meniscus tears, and we'll talk a little bit about that later. So that's kind of some more of your basic anatomy. And then you have the muscles here. So really it's the quadriceps muscles in the front of the thigh, the hamstring muscles in the back of the thigh. There's a few different sub-muscles that make up those groups. You have the iliotibial band, which runs from the kind of side of the hip down the side of the thigh to the outside of the knee. And then there's a little muscle in the back called the paphidius. So, how do you make a diagnosis of knee pain as a doctor? You're kind of playing detective, trying to figure out what's causing the pain. So some of the questions that you want to be thinking about are, what are the symptoms? Where is the pain located? How old is the patient? Because young patients have different knee problems than older patients. Is there a history of trauma or injury? Did they twist their knee? Did they fall? Did the pain start suddenly, or was it sort of a gradual onset? Is it with certain activities? And then in medical school we learned these mnemonic OPQRST. So the onset, what makes it palliative, provocative, what makes it better, what makes it worse, the quality of the pain, is it sharp, stabbing, dull, does it radiate anywhere, the severity of the pain and the timing of the pain. So that's sort of how we take a history.
He just holds the door.
Revolving.
Sorry, it's frozen.
Not my day today.
No.
What broke now?
It's
I'll just X that out.
Okay, that's probably
Update, I don't know.
not responding.
Oh, gee.
Hold on, I got it. All right,
Everything's breaking today.
Okay, we're back. All right, so some common symptoms that we ask about or that patients typically complain about is popping of the knee or cracking, also this crunching, grinding, or what we call crepitus, catching or locking, which is a big one that we always want to know about. It means if you can't straighten your knee or you can't bend your knee, if there's swelling, if there's pain, what kind of pain, and also does it give way or is there a feeling of instability in the knee. So the location of the pain. That's really, really important for trying to determine what might be causing your pain. So a lot of times, the first thing we ask is where does it hurt, right? So if it's the front of the knee, the most common cause of pain in the front of the knee is from the patella or from the kneecap. So there's different things that can cause pain from the patella. Chondromalacia patella, which basically means softening of the cartilage behind the kneecap. That can happen. Usually it's a tracking issue. It sort of goes in line with patellofemoral pain, which means pain from the kneecap sort of rubbing against the femur in the track. A lot of times that has to do with muscle imbalances. When some muscles are pulling more in one direction or the other, it can basically irritate the back of the kneecap and cause pain. You can also have tendinitis in the front of the knee from the patella to the tibia, the patellar tendon. You can also get something called fat pad impingement or plica, which is a synovial tissue that can sort of get pinched It's a little bit less common, but we do see that as well. If you're looking at the inside of the knee, people are complaining about the inside of the knee, which is sort of, where the two knees touch. Most common causes of pain at the inside of the knee are the medial meniscus, osteoarthritis, which is by far the #1 cause, especially in patients over 50, or medial collateral ligament sprains and strains. If you're looking at the outside of the knee, similar, lateral meniscus, lateral collateral ligament, iliotibial band, which is kind of a big one, which is, like, again, I remember I told you the little muscle that's connected all the way down the side of the thigh to the side of the knee, so a lot of times that can cause knee pain, and it's kind of hard to figure out sometimes. Also, osteoarthritis of the lateral compartment, or the outside of the knee. Arthritis is more common in the medial compartment, but certainly can be seen in both. Or, and this we see a lot, is referred pain from the back. So sciatica can also present like knee pain, so that can sometimes be really confusing. And then, of course, the back of the knee, you can get what's called a Baker cyst, which is basically an outpouching of synovial fluid when you have some arthritis or inflammation and it pokes out the back and you feel this sort of lump in the back of the knee. Sometimes that can cause pain, sometimes it doesn't. Again, sciatica or referred pain from the back can definitely cause pain in the back of the knee. And sometimes pain from the kneecap or patellar issues can cause pain in the back of the knee. So I'd say back of the knee pain is probably the least common, but we definitely do see it. We also want to know about timing. So when does it hurt? Is it with walking? That's most common. With arthritis and also with meniscus issues. Stairs, definitely arthritis, and then also patellar issues. So because when you're going up and down stairs, you're using your quad muscles, and that really puts a lot of pressure on the kneecap, so that can make that worse. Also, does it hurt first thing in the morning? Arthritis tends to hurt when you first get up in the morning before you get going, and also ligament issues tend to hurt first thing in the morning, because ligaments sort of like to be moved, and they tend to just complain a little bit when you've been resting for a long time and then first start moving. So next, we will do a physical exam. So first we inspect, right? We want to see, is there any discoloration, any bruising, especially if there was a history of trauma. Is there swelling? Is one side look bigger than the other? Are they symmetrical? And how's the alignment? Is the knee straight? Is it shaped like a V in one direction or another? And then, of course, you want to palpate. You want to palpate all the landmarks, the ligaments, the meniscus area, the joint line, and see if anything really hurts to touch. Then you also want to check for instability, so you want to make sure that none of the ligaments were torn. A lot of times you hear about athletes having ACL tears and things like that, so that can cause instability in the knee. And then there are some special tests that we do as well. And then, of course, patients always ask me, am I going to get an MRI? Do I need an X-ray? So we... in orthopedic practice, we get a lot of X-rays. So someone comes in with knee pain, especially a lot of doctors will get X-rays on everyone. I tend to save X-rays for patients over 50 unless there was a history of trauma. And again, I showed you the similar picture before, but you can see the difference from side to side. Can you see? I'm not blocking, right? So again, you have the femur bone, the tibia, and the fibula, and you're looking at the joint in the middle here, and you can see that there is a even space throughout. So this is a normal knee X-ray. You want to make sure there's a space because cartilage doesn't show up on an X-ray. So when you have cartilage, you expect to see a space. The other one, however, is a picture of arthritis. So you can see that the lateral compartment or the outside of the knee here, there's still a space, but as you go over to the inside of the knee, you lose that space and the bones are really close together. So that means that you've lost the cartilage because there's no space there. So in terms of treating knee pain, we always try to start from the most conservative treatment and then go towards the most aggressive. So surgery is always the last option unless there's something that happened where there has to be surgery done immediately, like a trauma, or in younger athletes sometimes surgery has to be done sooner. But generally, people would benefit from physical therapy because most of us do live rather sedentary lifestyles. Maybe we're a little overweight, maybe our muscles are not in balance. So for knee pain specifically, most of the studies show that quadriceps strengthening, which is the muscles that extend the knee, can reduce knee pain. Also, I always like to focus on the hip stabilizers because especially as you're walking and going up and down stairs, anytime you're standing on one leg, you're really counting on the muscles around your hip to kick in, and if it doesn't, that force gets transmitted down to the knee. Also flexibility, a lot of people, especially men, have really tight hamstrings or other tight muscles, and that can also alter the mechanics of the knee. And the quality of the therapy. And I can't tell you, I literally lecture every single patient about where they go for physical therapy because there's a lot of really bad therapy around and you can get stuck there for months. So if you go to a good therapist, you should be in and out of there in a couple months, and you really do see a big difference much of the time. So we work closely with therapists a lot. We speak to them a lot and really rely on good therapists to help us with this. Bracing can also help. Obviously the brace only works if you're wearing it, so that's usually the biggest issue for patients. It can help with stability, so especially if you have issues of instability and you're not a candidate for surgery or you don't want surgery, it can help to give you a little more support and stability, especially when you're walking or being more active. It can also provide some comfort. There are all different types of braces. I'm not going to get into them right now, but for arthritis, sometimes we try to unload the joint that has the most arthritis by offsetting the pressure in that area. Sometimes it's just a general support brace. So it really varies depending on the condition that we're treating. And then, of course, medications, are considered conservative treatment. The most common medications that are prescribed for knee pain are anti-inflammatories, or NSAIDs, which are non-steroidal anti-inflammatory medications, or acetaminophen, which is Tylenol. They can help to manage acute pain and help you to tolerate therapy, which is how I like to use them. Opioids are not recommended. I'm sure everyone's heard about the opioid crisis that's going on right now. We're really trying to move away from prescribing them unless there's really no other option. But medications do have side effects, and so I always tell patients, this is not a long-term solution. You never want to be taking an anti-inflammatory for your whole life or Tylenol for your whole life because, they do get processed and cleared through different organs, and over time those organs can get a little bit stressed out. And plus you have to worry about interactions with other medications, and also if you're on blood thinners, that pretty much knocks out the entire anti-inflammatory category. So that limits your medications quite a bit that you can take. Patients also always tell me, are there natural things I can do? Are there supplements I can take? Is there food I can eat? So there are some supplements that people ask me about a lot. Some of them have research supporting its use for knee pain, and some of it doesn't. People always ask me about glucosamine and chondroitin, which I think that the research on this is sort of mixed. The majority of the research says that we can't really say that it helps much. But generally speaking, it seems to help about 30% of patients. We just don't know how to identify that 30%. So what I usually tell people is try it for a month or two, and if you feel like it helps, maybe you're one of that 30%. Otherwise, it's probably a waste of your money. Hyaluronic acid is, sort of the natural lubricant that we make in our knee joints, and as we get older, we sort of stop making it. They do make tablets of that. I don't believe that there's any research to support that actually helps knee pain, but we do use it as an injection, which I'll talk about later. Calcium and magnesium is really helpful, is really good for your bone health in general, as is vitamin D. Vitamin D has a lot of interesting properties and maybe can help to reduce pain a little bit, but calcium and magnesium mainly is to help with the integrity of your bone. It doesn't really treat the pain from arthritis or other knee conditions. And then there are some spices. Turmeric is actually interesting. There's a lot of research being done on it, and actually some pretty interesting research has already been published that says that it really can help to reduce the pain from knee arthritis and other knee conditions. It's very safe. It works in a similar mechanism to other anti-inflammatories, but it doesn't irritate the stomach or cause ulcers or have all those other side effects. Other spices that are anti-inflammatory that I recommend to patients are things like cinnamon, pepper, sumac, and ginger. Again, harmless, have been shown to be anti-inflammatory, so having them in your foods can be beneficial. I just love magnesium, so I put a whole slide about it. I think it's really under-recommended. A lot of people are deficient in it, especially if you get cramps, a lot of muscle cramps, muscle aches. A lot of my patients love magnesium. You can get it topically, you can take it by mouth. And magnesium deficiency can cause all of these things. So, sleep problems, muscle tension, spasms, cramps, heart issues, high blood pressure, fatigue. So, yeah, I love magnesium. Also, there's a bunch of anti-inflammatory foods. I just pulled up one slide, but there's tons of them. Generally, I tell people, people say, what should I eat? I say, try to stick with more of an anti-inflammatory diet. And basically that means, eat food that's good for you. Don't eat processed foods, packaged foods, things that you don't understand the ingredients in them. Foods that are generally rich in omega-3s, antioxidants, probiotics are really good for you, and just, whole foods, cook your own food if you can. And then a huge one is weight control. The knees take a brunt of the force when you're walking, and every extra pound that you have is about 5 to 7 pounds of force on your knees. So if you have an extra 20 pounds, that's like an extra 100 pounds going across your knee every time you're walking. So it doesn't matter what else we do, if you're really, really overweight, Even if you can lose 10 pounds, that can make a huge difference. So I always counsel my patients on that. And then staying hydrated. You know, hydration is really great for the joints and all your muscles and everything. So make sure you drink enough water. So the next step, after we've exhausted those most conservative measures, is injections. So the first type of injection is corticosteroids. So that's easy. It's covered by basically every single insurance. It's used for the treatment mainly of internal knee issues. So that would be your internal knee pain, swelling in the knee or an effusion, arthritis, maybe meniscus issues. We really don't use this for treating ligament or tendon issues because you never want to inject a steroid directly into a ligament or a tendon because you can rupture it. I don't love steroids personally. They're temporary. It's an anti-inflammatory medication. It tends to last a few months, but for many people it's really the only option because their insurance doesn't cover other things, and it can provide relief. So we do use it. It definitely has a place. The next is hyaluronic acid, which is really indicated only for the treatment of knee arthritis. It's not approved for the treatment of any other type of arthritis. It is covered by Medicare right now, which is great, and some commercial insurances. Other insurances have stopped covering it because it's really rather expensive, but I really like it as an alternative to steroids because it's not a steroid. It's a lubricant. By definition, it's not even a medication, it's a device because you just inject it into the knee and it cushions and lubricates the joint. It doesn't really get absorbed into the body. Usually it's a series of 3 injections once a week for 3 weeks, and then it's repeated every 6 months. So for patients whom it works for, it can be a great option. You can get it for 6 months indefinitely. There's really no downside to it. Next is regenerative injections, which I will talk about, although I can tell you I have about 2 hours worth of material on this one slide alone, so I'm just going to touch on it a little bit, but I'll be happy to answer questions after. Basically, regenerative injections are sort of new. They're not really new because prolotherapy has been around since the 30s and PRP has been around since the 70s, but it's really just been gaining traction over the last 20 years or so. Basically, the way it works is that these injections, rather than trying to suppress inflammation to reduce pain, we're trying to harness the body's inflammation and turn it from kind of a destructive inflammation into a constructive inflammation that can attract stem cells and attract sort of the healing cells into the area and actually trick your body into thinking that you were just injured so that it tries to repair the injury in that area. So there's different types. The main 3 categories that I usually speak about are prolotherapy, which is a non-biologic, meaning we don't use any of your own cells. It's just a mild irritant that we draw up in the office and we inject it in, and it sort of stimulates the healing response there. It works really well for things like... Oh, shoot. Sorry.
Not going anywhere. That was, hit cancel.
No.
Did you shut it down?
I didn't. I did. I shut it down. No, wait.
Hit cancel.
Well, I can keep talking about it because there were no pictures. Sorry. Wrong button.
You ever see Airplane?
I have.
I never should have stopped alcohol this morning today. You ever see that scene?
Well, it was like the 5th time that it came up. I hit the right button the first 4 times.
All right. That's how I feel today. You ever see that scene with, I forgot who it is, who says, every time he keeps saying how she never should have stopped taking, there's some cigarettes and he goes alcohol and he starts,
Yep.
Remember that? I don't remember that scene.
I vaguely remember.
I did some heroin today. Just every time he keeps stepping up to worse and worse drugs until.
Yeah. Well, anyway, I'm happy to keep talking about this stuff because I know this pretty well. Anyway, as I was saying, so prolotherapy is a non-biologic. We basically draw it up in the office. We inject it into the knee or the tendon or the ligament or whatever is damaged, and basically over a period of weeks it starts to heal and the pain starts to go away. The next one is platelet-rich plasma injection, or a lot of patients call it plasma injections. You may have heard about it. Essentially, that is where we draw your blood, just like you would get your blood drawn in the doctor's office. We spin it down, and
You gotta turn it on. You turned it off.
I'm gonna let you do it.
Oh, it's starting Windows again.
Okay. So anyway, we basically draw your blood, we spin it down, and then we take the platelets, which are the healing cells essentially. So when you cut yourself, the first cells that go to that area to stop the bleeding are platelets. So they're packed full of all these growth factors and stuff because they're the first responders to injury. So when we try to isolate these cells and we, again, would inject them into the area of injury or the area of arthritis or whatever the case may be, and same idea, but it's just a little bit more of a strong injection, a little more potent. It comes with the growth factors already in there. And then the third type of the injection are the stem cell injections. There's really two types of stem cells that are used when you go see a doctor and you're asking about stem cells for this kind of a problem. You can either get it from the bone marrow or you can get it from the fat. Getting stem cells from fat is sort of a little iffy with the FDA right now, so we're mainly doing the bone marrow. And basically, same idea, we process it, we isolate and concentrate the stem cells, which a stem cell is basically a cell that can become other cells. It can become tendon cells, it can become cartilage cells, it can become muscle cells, or wherever the damage is. So people that have more degenerated tissues, worse arthritis, partial tears of the rotator cuff that maybe wouldn't respond to more conservative treatments, we would do that injection. So, I'll back up.
No,
there.
it's just exciting, but I think that now it's kind of,
Yes.
That's the gel, right?
The gel is the hyaluronic acid that I mentioned before. So that's the one that's covered by Medicare, that it's a series of 3 injections.
Yes, well, I had that.
Orthovisc or
It was
Synvisc.
5 injected, 5
Okay. Yeah, Hyalgan is usually 5. There's like
different.
a lot of different companies that make the same thing, yeah. So some of them are 1 injection, some of them are 3, some are 5.
What do those do, in fact?
They lubricate and cushion the joint. So you inject it into the joint and it just sort of coats the joint. And
For how long?
so it's done about 6 months. Yeah.
So once every 6 months, you get one injection?
No, like
Oh,
like we were just saying, yeah, it depends.
3 days.
You get it once a week for 3 weeks. Some companies do all in one. Some people do 5. It just depends on the company. Yeah,
That stuff that comes from the crowns or roosters, that's the advertised and.
that's exactly what we're talking about.
Oh, okay.
Yeah,
Thank you.
yeah. So the original one, Synvisc, was derived from rooster cone, but the ones they make now are made, they're made synthetically in the lab, but it's the same thing. It's just a little bit less allergenic because some people used to be allergic to, if you're allergic to eggs or chicken or something, you might react to it. So now it's not as allergenic. If anyone has any other questions while we're waiting for this to reboot, I can take
just about.
I was on they told me to take the cortisone, and then I tried this, and then I went back to the cortisone. I don't want to take too much of the cortisone, but I have no choice.
Yeah, I mean, that's sort of the conversation I end up having a lot. So the last slide, like the regenerative injections, unfortunately, those are not covered by insurance, and so they are an out-of-pocket expense. So
The
they're
cortisone.
no. The cortisone is covered by all insurances. The gel is covered by some insurances. And there's other injections like the stem cells and the other things that we're talking about. Those are not covered. Those are another option, but they're a little, they're expensive. So if you don't want to go that route and you're not ready for surgery, then you are going to kind of be bouncing between those 2 options, the cortisone and the gel probably. Yeah.
Are you better off as soon as you get a little bit of pain to start putting in injections, or you wait until you can't
I'm
handle
watching
it anymore
the
without?
screen here.
It depends what kind of
Before you
injection.
walk.
With the
Oh,
cortisone, I
I
usually.
have to watch the screen here. She has,
She hasn't started yet.
We'll be back up in a second. With cortisone, I usually don't like to do it as a first line because, like we said, we don't like to give too much of that. If you have arthritis on the x-ray and your knees are starting to bother you and you're covered for the gel injections, there is some evidence that says that it may help to protect the knee joint a little bit. It may help to, prevent the arthritis from progressing as quickly. We don't know really for sure, but, theoretically it's very safe and there's really no downside. So we might go in that direction a little bit sooner than with the cortisone. So you don't have to wait until you're really dying in pain.
But I was a little skeptical on this, with this gel. I was a little.
I mean, look, not everything works for everyone, so it's nice to have options. That's,
Yeah, right.
That's my thing. Yes.
I mean, I hear a lot about
Okay,
replacements. I know that that's the last
so I
resort.
get your thing back?
Sure.
Just 1 second there.
But how do you know when you reach the last resort?
Well,
Start with
like
the-
most, well, so, you know, you basically work your way through this whole PowerPoint, and if you get to the last slide, you're there.
Okay.
Let
We'll get there.
me just get my key back up.
Well, it should have been doing. But she has the laptop backwards. She wants to move the laptop. Oh, it's not reading the,
I just took it out and put it back in.
wait for the next thing to break today.
Don't say that.
Everything else broke today, I mean,
All right, we're good.
just put on,
Let me just get my slideshow.
you know what you're doing.
So you have to advance it.
Yeah.
Sometimes doctors don't really know what they're doing.
Yeah.
You just wanna,
All right, so where are we?
No, we didn't do all this.
We did all of this. We did all of this. So we did this. So basically cortisone, the gel that we were just talking about, right?
And it's not working. Hours.
It's probably gonna, hold on, probably wants to do some update or something. No, I don't, how do I not select it? Okay.
Good, good.
but they say error is human, but takes the computer with foul things.
Okay, so, like I was saying, so regenerative injections, that's my area of expertise, unfortunately not covered by insurance generally, but I think it's the future really of treating these conditions because the goal is really to repair and heal the body as opposed to just covering up the pain and waiting for a knee replacement. But sometimes you do end up needing it. So to answer your question, like, you know, most good knee surgeons that I know, they always say, you know, you'll tell me when you're ready. I mean, basically it's an elective surgery. You know, you never need to get it, but if you've done everything else and you're still having a lot of pain and you can't function, you can't walk, and it's limiting your quality of life, then that's when you would consider getting a knee replacement surgery. So the type of surgery really depends on the condition you have, right? As I said, you know, patients over 50, by far, osteoarthritis is the most common, and in those conditions, it's really usually a knee replacement. You know, it used to be that, you know, surgeons used to scope and, you know, clean up the meniscus and do surgery on that, but really we find that if we just leave the meniscus alone, you're generally better off, because if you take it out, it just leads to more advanced arthritis down the road. So we don't really mess with the meniscus unless it's causing locking or catching, where you're a young athlete with a big tear that needs to be repaired for you to continue to play. Orthoscopic surgeries, people always say, oh, is it going to be a big surgery? Is it going to be a scope? Scopes are usually done to just, you know, if you have some debris in the knee, again, if it's like a meniscus or a ligament thing, that can be done without making a big incision. But knee replacements are by far the most common treatment, surgical treatment for osteoarthritis. Recovery and weight-bearing status and all that stuff is going to depend on the surgery, the surgeon, even the kind of knee replacement that you have. And rehab after is nearly as important as the surgery itself. So if you get surgery done, you don't get good rehab after, your outcomes are not going to be as good. And again, surgery is always the last option, but it is nice to have good surgeons available when we need them. So I am not a surgeon, so I'm not going to get into any more detail about surgery than that. And with that, I will end it. So it's a sore knee. Have you tried icing it? And hold on.
No.
Which one do I hit?
No.
That's it. That's my baby. Thank you.
We have questions, I'm sure.
I have two questions.
Yes.
Are there any things about the radio waves being used as treatment? And I also heard that the more that you put up the surgery, the more that you have the pain before the surgery, that the more pain you're going to have post-surgery too, because that you shouldn't put off the surgery too long, so if the pain for too long before the surgery.
Yeah, there definitely is something to that. We know that good pain control prior to surgery can lead to better outcomes. So we do try to control the pain before any surgery is done, because like you said, you know, the brain does rewire, and it's used to being in pain. So that factor. As far as the like radio frequency ablations and things like that, so that's a technique where you can kind of burn the nerve, and that's usually done for spine arthritis. There is something being done right now called pulse radio frequency, where it doesn't really burn the nerve, but it sort of alternates pulses, and they do that. There are some people doing that for knee pain. It's experimental, I think you could say at this point.
Stimulation kind of?
Yeah, it sort of stimulates and neutralizes the little nerves around the knee. And I have spoken to some doctors that do it, and they do say that there are good results, but it's still kind of on the fringe right now. There's not a ton of evidence.
What's it called?
I don't believe it is, but I don't know for sure. It's called pulsed radio frequency.
Thank you very much.
I mean, is ice good or heat good?
So, very common question. There's really no good answer for that, honestly. I mean, we know that, you know, if you sprain your ankle for the first 48, 72 hours, ice is good. You know, we know if you have a muscle spasm, heat tends to be better at relaxing that. But other than that, I usually tell patients to play around with both and see what feels better. Because, you know, for arthritis, it's kind of like having a tooth that's sensitive to cold. Sometimes cold will make it worse. You know, a lot of people are sensitive to being outside in the cold, so heat is better. But other times they feel like there's just a lot of inflammation in the knee, so the ice helps with the inflammation. So it really just depends on the patient. Yes?
Yes. Are there any side effects to either of the injections? Because when I was speaking to orthopedics about my mother, she's in her 80s. She's basically in a wheelchair, but she walks a little. It's very painful for her to walk. And he said he doesn't recommend it because he said it's going to cause constipation, and she'll change one pound another time.
What?
So I was just wondering.
Constipation? I've never heard that. That's not a side effect I'm familiar with from any of these injections. Have you heard of that? I've never heard of that. Not constipation. Steroids do have side effects. Repeated exposure to steroids.
One of the injections, I don't know which one it was.
No. I don't think so. I mean, steroids do have side effects if you get repeatedly exposed to them, especially if you're old and thin and frail. If you have osteoporosis, that's a concern.
Opioids cause constipation.
Opioids cause constipation, but we don't inject opioids into the knee, so that's probably.
Quite early anywhere either.
We don't give them by, yeah, exactly. So, you know, they do have some side effects. And most of the side effects with steroid injections are temporary unless you're getting them over and over and over again. And those are things like facial flushing. If you're diabetic, it can raise your blood sugar. If you have high blood pressure, it can raise your blood pressure. It can keep you up at night. It's a stress hormone. So if you think about what your body needs to survive a stressful event, it does all those things. The gel injection, there's really no side effect to it. There's always a chance that you could have a reaction or an allergic reaction to it, and that's usually a localized reaction where your knee swells up. Knock on wood, I have never had an allergic reaction. They're pretty uncommon, but they do happen. And then with the other injections, the ones that are not covered by insurance that use your own cells, you can't really be allergic or react to your own cells, so those are pretty safe. Yes, sir.
When you have pain in the knee, let's say, there are several specialties that serve that population. One is a physiatrist and at least two others.
That's true.
How do you choose whom to go to first?
So that's a good question. I think that it should start with, you know, primary care doctors should know the basics of how to take care of knee pain because it's so common. So we try to make sure that, you know, we try to educate that. But aside, you know, if the primary care doctor wants to send to a specialist, the main three specialties are physiatry, rheumatology, and orthopedic surgery.
That's exactly what I meant.
Yeah. So orthopedic surgeons generally only want to see you if you need surgery. They will be happy to treat you if you don't need surgery, but you know they're surgeons and that's what they want to do. So that's why they work with physiatrists and rheumatologists and primary care sports doctors that can see a lot of those patients that aren't ready for surgery yet. So I think when people get referred to orthopedics, it's mainly either because they maybe don't know to refer to a physiatrist first or whatnot. Rheumatology, they do see osteoarthritis because they deal with every type of arthritis. I think that they generally deal with more systemic issues like rheumatoid arthritis, lupus, but they absolutely do treat osteoarthritis and they can treat it. And then physiatrists, again, depending on the subspecialty of the physiatry, like somebody like myself that works in an orthopedic practice, we treat this a ton. And you know, they're all good options. So it really doesn't matter unless you're looking for a very specific treatment. Any other questions?
I would like to make a couple of comments. First of all, we like to pun in this place a lot, and this was a genuinely wonderful presentation. I think maybe 3 people got that one. Genu is the Latin word for knee.
Reflects your punster.
A couple of comments.